The proximal femoral nail, PFN. The proximal femoral nail is an intramedullary implant for the treatment of unstable pertrochanteric and intertrochanteric femoral fractures. These are 3-1, A2, and A3 fractures, according to the AO classification. The proximal femoral nail has a total length of 240 millimeters. It has a proximal diameter of 17 millimeters and is available with shaft diameters of 10, 11, and 12 millimeters. The tip is specially shaped to reduce resistance during insertion and to minimize stress concentration and tension in the femoral shaft. The angle between the proximal part and the shaft measures 6 degrees. A load-bearing 11 millimeter femoral neck screw with a safety stop at the end to prevent the screw from pushing through the nail is used to attach the head-neck fragment to the femoral shaft. In order to prevent unintentional rotation of the head-neck fragment, a 6.5 millimeter hip pin is also placed as an anti-rotational screw through the proximal part of the nail and the head-neck fragment parallel to the neck screw, at a fixed distance. This pin, like the neck screw, has a shoulder at its head to prevent protrusion through the nail. The nail is suitable for both the left and right femur. Static or dynamic distal interlocking of the nail is achieved by using the upper or lower distal hole, respectively. The caudal distal hole is oval-shaped to allow primary or secondary dynamization. Finally, an end cap is placed in the top of the nail to prevent tissue ingrowth. Although surgery can be performed on a normal table, usually a fracture table will be used. The affected leg is positioned in a slight adduction position for easy access to the trochanter tip. 1 or 2 image intensifier C-arms can be used. Their position should allow good AP and lateral views of both the proximal femoral area and the femoral head. After closed reduction of the fracture, one of the available 2 image intensifier arms is used to check the reduction. Also in these fractures, precise closed reduction is the cornerstone of successful treatment. The instruments required for creating the entry hole for the PFN are a 2.8 millimeter guide wire with threaded tip, the 2.8 millimeter trocar, the drill sleeve, the protection sleeve, and the 17 millimeter cannulated drill bit with stop to prevent over-drilling. As the opening should be performed manually, the universal chuck with T-handle is used. The ideal entry point for this exercise lies on or slightly lateral to the tip of the greater trochanter and should be in line with the axis of the femoral neck, which is shown as a red line, and lateral to the femoral shaft axis, shown as a blue dot. In the AP view, the greater trochanter, its tip, and the femoral axis, shown here as a blue line, should be identified. The opening of the medullary canal begins with the insertion of the 2.8 millimeter guide wire at the ideal entry point, using image intensifier control in 2 planes to monitor its position. Remove the universal chuck with T-handle. The protection sleeve and drill sleeve are inserted over the guide wire. After removing the drill sleeve, the 17 millimeter cannulated drill bit is introduced through the protection sleeve. The medullary canal is opened as much as the drill stop allows. This procedure should be performed under image intensifier control. The drill bit, protection sleeve, and guide wire are now removed. As an alternative, the medullary canal can be opened with the 2.8 millimeter guide wire, over which the cannulated reverse awl is used. A tissue protector is also required. Now the proximal femoral nail is mounted on the insertion handle. The shaft diameter of the nail has already been determined during preparation for surgery. The connecting screw is then inserted into the handle, and the hexagonal wrench with T-handle is used to fix the connecting screw to the nail. Owing to the handle tongues and the nail grooves, there's only one way the proximal femoral nail can be attached to the insertion handle. The nail must be secured tightly to the handle. The nail can be inserted into the shaft manually with slight twisting movements. Hammering is usually not necessary. The position of the nail is verified either under the image intensifier or by using a K-wire through the marked hole in the insertion handle to determine if the tip of the nail is flush with the tip of the trochanter. It's better, however, to determine the position of the nail by adjusting it so that the neck screw is close to the calcar of the head-neck fragment. If necessary, insertion can be supported by light hammer blows onto the protection shield of the insertion handle. Never hit other parts. Now the aiming arm is attached to the insertion handle. Color codes on the aiming arm correspond to the appropriate insertion instruments and implants. For the insertion of the red femoral neck screw, the 2.8 millimeter trocar, the 11 millimeter drill sleeve, and the 14 millimeter protection sleeve, all color-coded red, are used. A 2.8 millimeter K-wire with threaded tip is used as a guide wire. For insertion of the blue anti-rotational screw, the 2.8 millimeter trocar, the 6.5 millimeter drill sleeve, and the 8 millimeter protection sleeve, all color-coded blue, are used. Again, a 2.8 millimeter K-wire with threaded tip is used as a guide wire. The aiming arm is now firmly attached to the insertion handle. The ideal position of the guide wire for the femoral neck screw is in the center of the distal half of the femoral neck, seen in an AP view. Prior to the insertion of the K-wire, the future position can be verified by positioning another K-wire alongside the femoral neck under image intensifier control. The position of the hip pin is determined by the position of the guide wire for the neck screw. Prior to the insertion of the neck screw guide wire, the position of the aiming arm should be verified. In a lateral view, it should be parallel to the femoral neck. This will prevent malpositioning of both screws. First, the red protection sleeve with drill sleeve and trocar is inserted through the appropriate hole. After removing the trocar, the 2.8 millimeter guide wire is inserted through the drill sleeve into the femoral neck. During this maneuver, the progression of the guide wire should be monitored under image intensifier control in two planes. The guide wire should be placed 5 millimeters deeper into the femoral head than the planned neck screw. Ideally, this is in the subchondral bone of the femoral head. After insertion of the neck screw guide wire, the same procedure is repeated for the hip pin. The blue system of protection sleeve, drill sleeve, and trocar is placed through the appropriate hole. After removing the trocar, again a 2.8 millimeter guide wire is inserted into the femoral neck. The tip of the guide wire should be at least 25 millimeters medial of the fracture line. Its position should be verified in 2 planes under the image intensifier. First, the hip pin is inserted. We will use the direct measuring device, the 6.5 millimeter cannulated drill bit with stop, the appropriate pin, and the cannulated hexagonal screwdriver with stop. In young people with hard cancellous bone in the femoral neck, a specially designed tap is to be used. For the insertion of the neck screw, we need the direct measuring device and the 11 millimeter reamer and the fixation sleeve. Also the coupling screw, the T-handle, the compression nut, and finally the appropriate neck screw. After removing the 6.5 millimeter drill sleeve, the length of the hip pin can be estimated with the measuring device. The reading indicates the appropriate pin length. After insertion, the pin tip will lie 5 millimeters before the tip of the guide wire. Then the 6.5 millimeter cannulated drill bit is inserted over the 2.8 millimeter guide wire and the hole is drilled as far as possible. Drilling is limited to 45 millimeters, but no further drilling is required. The self-tapping tip of the hip pin makes further drilling unnecessary. In young people, however, tapping may be helpful. After removing the drill bit, the hip pin is inserted over the guide wire. The final position is reached when the stop of the screwdriver hits the protection sleeve. Check the screw position under the image intensifier. After positioning the hip pin, the guide wire is removed. The 11 millimeter drill sleeve of the femoral neck screw is now removed and the length of the screw is determined with the direct measuring device. Again, the reading indicates the appropriate screw length that will place the screw 5 millimeters before the tip of the guide wire. The measured length is transferred to the 11 millimeter reamer by adjusting the fixation sleeve to the correct position. Advance the reamer over the 2.8 millimeter guide wire and through the protection sleeve to the bone. Drill until the stop. With the fixation sleeve in place, drilling is limited to the desired length. The progression of the reamer is checked under image intensification. Remove the reamer. Tapping is not necessary because of the self-tapping tip of the femoral neck screw. The wrench for the femoral neck screw is now assembled. First, adjust the compression nut to the T-handle and ensure that it's fully extended in a lateral direction. Normally, compression should not be applied. Then the appropriate length neck screw is fixed to the T-handle with the coupling screw. The neck screw must be firmly attached to the wrench. The femoral neck screw is now inserted over the guide wire into the femur as far as possible. Positioning of the next screw is checked under image intensification. The wrench can now be removed. If the coupling screw was attached too tightly, the combination wrench is now used to loosen it. The guide wires and the protection sleeves for the femoral neck screw and the hip pin are removed. Distal interlocking is now performed. For static interlocking, the cranial distal interlocking hole is used. For dynamic interlocking, the caudal oval-shaped distal hole is used. This may be indicated in 3-1-A3 fractures. The instruments for distal interlocking are the 4 mm trocar, the 8 mm drill sleeve, and the 11 mm protection sleeve. The 4 mm drill bit, the depth gauge as an optional instrument, and 4.9 mm locking bolts, which are inserted with the hexagonal screwdriver. The protection sleeve, the drill sleeve, and the trocar are assembled and inserted through the aiming arm onto the bone. After removing the trocar, the hole is drilled with the 4 mm drill bit through both cortices. Then the length of the locking bolt is measured. The length can be read directly from the drill bit. The drill sleeve is removed and the appropriate locking bolt inserted through the protection sleeve using the hexagonal screwdriver. The insertion instruments are now removed by loosening the connection screw with the combination wrench. The end cap is aligned with the nail axis using the hexagonal screwdriver and screwed completely into the nail. The final position is verified under the image intensifier and illustrated with this graphic. For removal of the proximal femoral nail, the following instruments are used. The extraction guide rod, which can be fixed with a pin wrench. And the slotted hammer, which is attached to the extraction guide rod. First, the end cap is removed. Next, the extraction guide rod is fixed to the nail. Now the distal interlocking bolt, as well as the anti-rotational screw and the neck screw, are removed with the insertion instruments. If the soft tissue situation requires, the femoral neck screw and the hip pin can be removed before mounting the extraction guide rod. However, at least one locking bolt should be left when mounting the extraction device, in order to prevent rotation of the nail. To ease the removal of the anti-rotational screw, an extraction holding sleeve is available. After removal of all screws and bolts, the slotted hammer is attached to the extraction guide rod, and the proximal femoral nail is removed with slight hammer blows.